Good afternoon, ladies and gentlemen. My name is Khaled Al Ahmed. I'm a student here at the SDM Master's Program at MIT. I'm also sponsored by Saudi Aramco, the Saudi Arabian oil company. Most of us are very interested in healthcare providers and consumers. Fortunately for us, Dr. Roberto Rocha is here to talk about clinical knowledge management at scale. Dr. Rocha is the Senior Corporate Manager for Knowledge Management and Clinical Decision Support in the Clinical Informatics Research and Development Group at Partners Healthcare Systems. He is also a faculty member of the Division of General Internal Medicine and Primary Care at Brigham and Women's Hospital and Harvard Medical School. At Partners, Dr. Rocha leads a team of over 20 clinical knowledge engineers responsible for the design, implementation, and long-term maintenance of a variety of enterprise knowledge bases integrated with clinical systems and accessible to clinical healthcare providers. Dr. Rocha received his MD from the Federal University of Paraná in Brazil. He completed a PhD in medical informatics from the University of Utah. Ladies and gentlemen, please welcome Dr. Rocha.
It's a pleasure to be here. I have been attending the conference since yesterday. It has been a fantastic experience for me. I don't think I quite speak necessarily the same language, so I will ask you guys to help us understand how the so-called system thinking applies to some of the things that we're trying to do. The objective today would be to drill down from some of the things that Blackford was talking about in terms of computerized clinical decision support, talking a little bit more about the motivation for it and the types of decision support that you typically see in clinical systems. And then look closely at how you produce the knowledge that is required for those clinical decision support interventions to occur, which is really kind of what I've been doing in the past 10 years or so. It's really looking at a system that can help us produce the knowledge in a reliable and consistent way. And then try to look towards the end into challenges and opportunities in trying to scale this model up, particularly given some of the incentives that have been discussed in terms of trying to promote the adoption of healthcare IT, particularly to promote the adoption of technology that can really help with decision making. So let's start with decision support. And I wanted to start with a simple example, because just to illustrate in very concrete terms what we are talking about. So this is an order entry system at our institution, and it's what we call a provider order entry system. And in this case, what we are seeing here is that the provider is trying to prescribe a medication, right? This is a cholesterol-lowering medication. And the provider receives a message, which is demonstrated here in the bottom, basically indicating that there is a potential drug-drug interaction, right? We refer to these things typically as DDIs, right? But there is a drug-drug interaction. And this particular alert is suggesting that whomever is prescribing that drug should take a look, because there is that the drug that is being prescribed and another drug that the patient is receiving, have some type of a chemical interactive that would provide, may cause lesion into the muscular system of that patient. So this is sort of a quote-unquote a benign type of alert, right? The provider can ignore. If we really think that is something really serious, then we surface a very different kind of drug-drug interaction alert, which really would force the provider to take an action. And in this particular case, we're going to force the clinician to basically either cancel the order that is being made or discontinue that medication that was interacting with that particular order. So this is what kind of an extreme case where we really think there's going to be a sort of a life-threatening condition for the patient, and we want the clinician to change the course of the therapy. There is always something in between, right? This is the third kind, right, where we really are suggesting an action, but we are not necessarily forcing the action, and we allow, in fact, the clinician to basically justify why he or she wants to continue to use the two medications. In other words, we allow him or her to basically offer a reason for that override. In the same systems, and in fact in the same screen, there is a very different kind of, another different type of decision support. You can see there's a little icon right next to the medication that is being prescribed, which is what we call an info button, right? So it's going towards the opportunity of trying to bring information to the point of decision, right? Try to make it extremely simple for that clinician that may or may not know, some details about the drug that he or she is about to prescribe, or maybe how that drug behaves in the condition that that particular patient has in terms of age or pregnancy and so forth, and give that provider an opportunity to go retrieve information that might help with that knowledge gap. So by clicking at that little eye icon, a new application is launched. That application at Partners is known as Knowledge Link, right? And what Knowledge Link does is essentially it launches a query against a series of electronic resources that we maintain, and some of which we subscribe from external sources, that brings kind of a complete, in this case, a complete drug monograph describing this particular medication, right? What are the classes, what's the adult dose, the pediatric dose, and so forth. And once in looking at this application, obviously the user has the opportunity to search for something else, or if he doesn't look like the information here, he can go back and choose another piece of information from a different source, right? So it's relatively simple. The goal is something like an info button, is to obviously try to anticipate as much as we can the question that is going to be asked, and try to provide the answer with a single click or 2 clicks at the most. So looking back at the different modalities of decision support, I would like to just basically go through some of the types of decision support that you typically see in an electronic health record. The first one is the one that we just saw, right? So it's some mechanism to allow you to select and retrieve reference knowledge from different sources, right? And info buttons are the typical example here. The second kind is one of the examples that Blackford had at the end, is just the ability to aggregate data and present the data in a way that facilitates understanding and consequently, decision making. The third kind is data entry system. That was also another example that Blackford has shown, where we're really trying to help or guide the user towards the collection of the data that is relevant, either to document what is being done, the treatment plan that is being proposed, or also to investigate, other diagnostic opportunities. The fourth one is event monitors. That's the first example that we had, right? The alerts in trying to, the drug-drug interaction alert is really an example of an event monitor. The fifth one is substantially more sophisticated, right? Now you're trying to incorporate decision support and workflow together, and you're trying to become more prescriptive in terms of what you want to happen with that particular patient. Healthcare has seen a fair amount of success with these things, but relatively, when they are constrained to relatively narrow domains. Things in this area will be computerized protocol, care pathways, practice guidelines. There's a lot of discussion, there's a lot of research related to this area of care flow assistance, but the reality is that very few systems do it well in a production-based deployment. And then the sixth type of decision support is perhaps the least explored one, the newest one, which is really through looking at the data, right, and looking at predictive and descriptive modeling to try to understand what's going on with that particular patient as it relates to other patients, perhaps similar to that one that you might have seen in the past. And the nice thing about this type of modeling that allows you to focus not only on treatment planning, but also on diagnosis, prognosis, as well as trying to anticipate treatment outcomes. So these are the modalities of CDS. So if we go back and we look at medication ordering again, I think as you would expect, there are many different types of decision support that play a role or that are potentially applicable to the medication ordering workflow. And I listed here those that are available in the system that I just showed. Right? So you can use decision support to check for duplicate medications, for check to see if the medication is or is not in the formulary of the hospital, to restrict if that medication has, for some reason, either because it's too expensive or requires specialized management, that it has to be approved for use, food and drug discussions, those calculations, and so forth. You see the pattern here. Obviously, when the clinicians are prescribing the medication, they seldom interact with all these types of decision support. If they did, they would obviously be, very likely overwhelmed. But all of these things are at play when that medication order is being placed, and the system has to be smart enough to recognize which one should be surfaced based on, on some degree of severity. The ones, just to give you a clue, the things that have the red tag right on the top would be the ones that are typically more severe. There is a fair amount of evidence out there in terms of the benefits of decision support. This is just one study, right? A systematic review of 70 studies, randomized trials, up to 2003, and it was really looking at the ability of clinical decision support to improve clinical practice, right? And it was really focusing what are the critical CDS, what are the critical clinical decision support features that have to be present for that success to be confirmed. So CDS would improve practice in about 68% of the trials, and the key predictors here are extremely important because they have a fairly direct effect on how you produce the knowledge. These are the things that you have to take into account when you're trying to design a system that allows you to produce knowledge, right? So you have to obviously understand the workflow and be part of the workflow, right? You have to provide recommendations just as opposed to just assessments, so help the user do the right thing, right? Time and location of decision making is very important, so you have to model that context, and I have another slide that goes into that in a little bit more detail later. And data is critical, right? So the triggering mechanism generally is data, and the sophistication of the decision support you can provide is also dependent on how much data you have. It's interesting because this study is from 2003. There is really not a lot of things here related to patient-specific guidance, which is something that I'm going to talk briefly in a few minutes, just to illustrate that this is going to become a lot more complex as we move forward. Blackford talked about point-of-care information needs, right? The famous discovery that 2 questions for every 3 patients seen. There was another study done later that was looking, okay, so if you do have a question, why don't you pursue the answer, right? And the idea there is that answers was pursued only 55% of the time, and there was an underlying assumption that, well, I didn't look for the answer because I don't think it existed, right? In other words, the information that is available is not easily consumable at the point of care. You have to remember that a clinical encounter is usually measured in minutes, right? And it's really usually around 12 to 15 to 20 minutes at the most. So if you really have questions and you have to go and open a book and try to find that information in a book, you are obviously not going to have the time to do so, right? Interesting also is that the most common source of information was a colleague or a peer, right? In other words, an information consultation, or the traditional textbook. The electronics resource, only 16% of the time. So why is that? And if you look now at the literature, at the science that is being produced, and I'm looking at this as biomedical science in general, there is a very interesting trend that is happening, and it was alluded before by Blackford as well, right? So if you look at the number of citations that are being published every year, right, you are seeing that the curve is just going, it's going up. It reminds me of the carbon curve that we saw, yesterday. It just keeps going up, right? So you have over 18 million citations total, and this is data from 2008. The particular database we are looking is the Medline, PubMed database, which is maintained by the National Library of Medicine. And the most interesting piece is that 50% of those citations were generated since 1991. Since I graduated before 1991, I'm kind of out of luck, right? Because the number of these things doubled in the past 20 years or so. There are studies that have done, right? If I am a practicing clinician, how much do I need to read on a daily basis to try to keep current in what is going on? And it turns out that task is actually impossible. You would have to read nonstop, and you're still not going to catch up, right? So one important mechanism that the scientific community came up with is to develop what we call systematic reviews. So there are studies that analyze other studies and try to bring the evidence in a somewhat concise and distilled way, right? The problem is that these systematic reviews themselves are becoming obsolete relatively quickly, right? In fact, this is the traditional, survival curves applied to those systematic reviews, which is kind of an ingenious approach. But it basically says that the median survival time of these, summaries really is about 5.5 years, right? So even the mechanism that the scientific community uses to try to deal with the advanced information explosion, right, it is really not very effective because you have to, refresh the studies on a very frequent basis. And then to make matters worse, right, if we look at the evolution, right, medicine is evolving from what has been described for some people as kind of an empirical medicine where you're really looking at a generalization based on a population or a subpopulation that was studied, and you try to apply that evidence to every single patient that you see, right? For the most part, statistics is on our side, and it works, right? In other words, if you control, if whomever you're treating, is similar to the population in which that evidence was developed, then the outcome is likely to be okay. The problem is as we learn more and more on how individuals, how patients react to treatments, and we understand more and more how diseases manifest themselves into patients. What we're really saying is that we are expanding dramatically the diagnostic scope, and we are reducing dramatically the therapeutic scope. So the number of variables that any clinician has to deal with at a given point in time in the decision-making process is about to become a lot more complicated, up to a point, right, which this may become individualized, right? So the treatment is going to be for that individual or for a very limited number of people that share that same set of characteristics. Genetic testing is becoming routine, right? Some people ask, well, this is nice. I mean, I've been hearing about, personalized medicine and individualized medicine for quite some time. When is it coming? Well, it's here, right? It may not be here at the volume that people would expect, but it's definitely here. So this is a publication from the FDA from March of this year, basically suggesting that you should be doing genetic testing if you're planning to use this particular drug, right? So it's recognized that this has a very important clinical relevance, and you have to and you have to account for it. So bringing back clinical decision support, you've seen this slide before. And the intent here of showing it again is really there's a fair amount of reliance from a healthcare strategy or healthcare IT adoption strategy on clinical decision support, right? In fact, it is spelled out as the stage 3. The goal of stage 3 in meaningful use is to get advanced care processes with decision support. But the challenge is how to produce the knowledge that is going to be required for systems to deliver this type of interventions, right? And it gets even worse as you move into stage 4 because the sophistication of your interventions have to be such that they are really, in fact, contributing to improved outcomes as opposed to simply correcting process problems. Luckily or unfortunately, it doesn't stop there, right? So this was a study that was published in 2007, but it's continuing and is being refined as we go. This is the notion of a learning healthcare system. This was proposed by the Institute of Medicine in 2007. And the idea here is that by 2020, 90% of the clinical decisions will be supported by accurate, timely, and up-to-date clinical information, right? And they will reflect the best available evidence and inform personal preference. So this goes beyond the notion of what I had been saying up to this point was really, okay, I need to find a way to engineer methods to extract and prepare the best available evidence. This also brings into the perspective the notion that you now have also to take into account preferences, right? So it's bringing the individual component on the decision making. ONC and IOM continue to collaborate, as I have said, right? And the emphasis now is to define what is going to be this electronic infrastructure for continuous learning so we could reach 2020 with that kind of infrastructure in place. Not necessarily the results, but at least drive towards that infrastructure. And if we go back to that graph, it's really kind of where this arrow is taking us, right? It's this notion of a learning healthcare system. meaningful use, and these initial 4 steps are really paving the way towards this notion of a learning healthcare system. So switching gears a bit and looking now at how do we go about producing the knowledge, right? So the notion of a clinical knowledge management system is really a system that can support the implementation and management of computer accessible and computer interpretable clinical knowledge. So I'm trying to intentionally stay away from free text, right, to put it bluntly, right? So I don't, we have a wide variety and a wide, a gigantic amount of knowledge that could be interpreted as knowledge that exists in narrative form. I mean, those 18 million citations that I mentioned a minute ago are a pretty good illustration of that. But we really need to move in this direction, right? We need to move in a way that this knowledge becomes, initially declarative, so I can act upon it, and eventually become something that can help guide the decision-making and the workflow. I have to acknowledge that I'm going to be dealing with a wide variety of knowledge assets, that these knowledge assets will have overlapping, life cycles. And that'll be, I'll have to maximize the opportunity in terms of choosing which intervention I'm going to be using. Okay? There's a lot of this, this notion of clinical decision support is not new, right? So there's a pretty well-defined set of criteria. What are the requirements for a good CDS intervention in terms of, using the best practice, covering, the problem in detail, being updatable, providing links. It's also obviously important to the fact that the clinician is in control, and the clinician can, take into account, pieces of information or preferences that perhaps are not represented in the knowledge base itself. I think it would be intuitive to assume what I'm trying to display here in this diagram, right? So if I try to look at the same modalities that we saw a minute ago, going from reference to information aggregation to data entry and so forth, right? It becomes extremely complex and costly to move from text all the way to executable, right? So what we really have in abundance, right, and available and easier to maintain, are really what we describe as reference knowledge, right? So the effort is to create a mechanism to make, this not so complex and obviously not so expensive to produce, because there's a lot of reliance in terms of the healthcare IT strategy on the so-called executable types of decision support. I don't want to spend too much time here, but I want to just highlight what is the typical process to produce, right, a piece of knowledge. So this is a knowledge life cycle, right? Generation, acquisition, representation, deployment, and maintenance. And this is the knowledge life cycle for medication rules and medication alerts. I mean, hopefully there's nothing extraneous here, right? So the idea is that either when a medication is added to the dictionary that we use at partners, that triggers, right, the investigation if that medication should be considered for a new drug-drug interaction rule, or perhaps added to an existing drug-drug interaction rule, right? Clinical experts, internal experts are asked to provide an opinion, right? And if we have access to reference sources that could perhaps offer additional information about that new medication and its, pharmacodynamic properties and so forth, they are obviously called to be used. The knowledge engineer goes through an acquisition phase, trying to really validate what is being proposed and what will be the best approach to do it. We then go into the actual representation of that rule, right, which in this particular case relies on a piece of software that is used to encode that rule and make it into a format that the system can execute. Testing occurs, it's released for production, and then we go into kind of a quote-unquote a maintenance mode where we expect to not only understand how it's used and how many times it gets overridden and so forth, but also to see if there's any new literature or any new information, that sheds a light on the behavior of that particular medication. If we put this into sort of like a diagram of a cycle, illustrating who participates in each one of these phases, right? So the KE is a knowledge engineer, SME is a subject matter expert, right? These people for this particular type of life cycle are typically pharmacists or informaticians or clinicians, right? Physicians. And the notion that in this type of life cycle, we rely on knowledge that it exists and is curated and maintained by commercial sources, typically biomedical publishers. The size of the knowledge base we are talking about is about 2,900 rules that exist for drug-drug interactions at partners today. And we touch close to about 50 or so every month, right? So this has kind of continuous maintenance. There are other mechanisms to produce the knowledge and consume the knowledge, right? So what we have here in this slide is a cycle where we kind of own the generation to some degree. Obviously, we did not investigate or discover the pharmacodynamic properties of the medication. That came to us via scientific literature or one of the external references. But we are responsible for the entire knowledge engineering life cycle. The alternative here is, well, maybe someone is doing that initial acquisition and representation for you, and the only thing that you need to do is to import that set of rules. You configure according to what your system is going to do, you deploy it in your electronic health record, and then you go into an update mode. So that's definitely a model, and we have in some cases that model. Another alternative is, well, someone is not only doing the acquisition and representation, but they offer the execution as well, and you use a service, for instance, that they provide to do that. You still have to do the configuration and obviously the integration with your system. Just to make things more interesting, this is the reality of what we have, right? So, and I obviously run out of space in this slide, but the notion here is that we have, combinations of these different types of life cycles for every type of knowledge asset that we have to deal with, right? So there's probably 50 to 60, workflows just like these, right, that we have to deal with within an organization of the size of partners. I don't think necessarily that we can be considered the typical healthcare organization. Probably are more towards kind of the high end. But it's inevitable that this type of complexity is going to have to be dealt with if you really believe that clinical decision support is going to become the core strategy for improving medical outcomes the way that the incentives that the government are pointing to. As one would expect, right, these things are interrelated, right? So whatever I do with the dictionary, affects how I order, how I create the order sets, how I index the monographs, create the templates, organize the rules and so forth. So these things are, there's a fair amount of, dependency management that has to happen, right? And this is obviously not necessarily always well done because there are silos, right? Especially if I end up, using processes that are not provided by the same vendor or are not implemented using the same set of tools, I end up having to do dependency management by hand, right, manually. So if you want to summarize what we want to accomplish with this clinical knowledge management system at our partners, right, we want to make sure that all knowledge content is accessible, updatable, maintained with an audit trail, right, that we reduce the cost and increase the efficiency to design and implement and also maintain. We have stakeholder involvement, right? You saw we try to get not only the expert, but also the clinicians involved with the process, the people that are going to use it. We obviously have to be, healthcare is a highly regulated sector, and there's a lot of things related to quality measures and compliance and accreditation that have to be, paid attention to, and we have to comply with. So there are business drivers that, in a sense, help the whole mission of what clinical knowledge management is trying to apply. And ultimately, we obviously want to avoid the liability of making incorrect or incomplete recommendations due to the lack of coverage, something that we don't know, or maybe something that is obsolete. So we come up with, in this diagram, we try to summarize what this clinical knowledge management system has in terms of components, right? So there's obviously people, and people, as usual, is the most important part, right? So we have domain experts, knowledge engineers, knowledge modelers, and terminology engineers that make up, this notion of a system. We have a framework, and it's really kind of a socio-technical framework, if you wish, because we are lumping together here the notion of the life cycle itself, as well as the governance, which is kind of a social, there's obviously a heavy social aspect into it. And then the notion of the software platform that has to be in place to help, make this happen. And then the assets themselves, or the knowledge bases themselves. And we put a lot of emphasis in trying to do this with meta models, right? So we recognize that we're going to have to grow and make the system become more and more sophisticated over time. So we try to make it in a way that is extensible. The next few slides go into more details about the requirements. And in the interest of time, I don't want to spend too much time describing each one. I'm just going to try to highlight the main points. And obviously, you have copies, so you can look at them in more detail if you want. So the notion of a multidisciplinary team, the notion of getting a clinician or a pharmacist and teaching that pharmacist to become a knowledge engineer is not necessarily a trivial process, right? As you remember, one thing is to read the literature and understand what is being proposed, discuss with the pharmacists, the practicing pharmacists, and the clinicians. I mean, all of that they learn in school, right? The moment that I try now to formally represent that information in a way that is computer executable, then you have to add some skills for that type of activity. So we end up having people that specialize themselves, right? They specialize by the modality of decision support or by the clinical domain or the type of asset and so forth. Recruiting and retention is an interesting challenge. There are not that many clinical knowledge engineers around the country, right? So as you can imagine, especially now that everybody sort of needs this type of professional, it has been pretty interesting to keep them around and find new ones as well. In terms of life cycle, the integration is critical, right? The notion of provenance, management of dependencies, process automation is key, particularly if you imagine that there's a lot of these processes co-occurring at the same time and overlapping. Version ownership, the notion of having something that helps you validate so you don't have to do a lot of the checking by hand. And it's very important to have an analytical framework and the so-called user-initiated feedback to try to keep you, current and moving forward. Distribution and collaboration is something that we believe a lot. We don't imagine that we're going to end up with a team that manages knowledge for the entire corporation, right? So we don't believe that we can centralize everything. So we are trying to create this in a way that we can empower other groups within the organization to do the same. And the notion is that this will be scalable at a much broader level as well. So different organizations will end up doing different pieces of the activity. Active maintenance, right? The notion of being introspective. So you have to rely on technology to help you maintain, right? Because manual maintenance obviously is extremely costly. Governance is critical. Intra-organizational, inter-organizational, obviously. Clinical vision and leadership has to be aligned with the notion of, managing knowledge for clinical decision support. Opportunities have to be identified, right? Clinical knowledge management has to be seen as an official model for knowledge translation, right? For trying to help the organization, help the provider deal with the knowledge explosion problem. And then, obviously, you have to be very careful about getting our stakeholders involved with the planning and the execution. I mean, one of the things that, we struggle quite frequently is the availability of the so-called domain expert, right? So you have to have sufficient buy-in and understanding and alignment with the strategy so we can get the opinion leaders as well as the domain experts to participate and quote-unquote be on your side. Software platform, I mean, those of you that are more involved with technology, I think would recognize and identify the things that you would expect. I would really focus on kind of the last two bullets, the notion of learning, right? So the system has to be a learning system by itself as well, not only enable learning from a knowledge worker provider perspective, but the system itself has to learn based on how the user is consuming the knowledge. And you have to manage as much as you can with meta-knowledge. The content assets, again, I don't think there are going to be any surprises here. This becomes an authoritative source. One of the least efficient ways to do knowledge management is to allow it to flourish everywhere in the organization, and then suddenly you have, 5 groups that are maintaining drug-drug interactions, right? Well, if it was already expensive to do it once, if you're going to have to do it 5 times, I mean, it's pretty straightforward to understand that doesn't make sense. The notion of structural and semantic properties are obviously very important, right? The notion of context, right? I said I was going to come back to this. So as you're modeling a particular type of knowledge asset, it's extremely important to understand, how to properly model the context in which that particular asset is applicable and how it should be rendered, right? And this is where things get extremely interesting and consequently complicated, right? Because you have, the list keeps growing, right? You have to take into account a lot of information, and you're becoming, that notion that increased diagnostic space, reduced, treatment space, plays a big role here. So this knowledge base is actually going to grow, and the specificity of this knowledge asset is going to become fairly narrow or fairly well defined. One other important point is that, you have to keep links to external sources as well. Again, the assumption is not a single institution or a single provider that is going to be able to manage all of this. So you have to be able to, leverage what comes from outside and interoperate with those components as well. So let's take a look at some of the challenges and opportunity, and hopefully we're going to have some time for questions. So what are the expected benefits, right? I debated if I should have put this slide right at the beginning, but I thought it, towards the end, I think it actually hopefully makes more sense. So improve the efficiency, improve the reliability of the knowledge content creation and maintenance process. So this is the whole proposal, value proposition of us, a clinical knowledge management system. So you want to, to the extent possible, standardize and unify the authoring, eliminate redundant content editing. You have to manage the dependencies, as I mentioned a couple of times, and you have to use reference sources and external sources whenever possible. There is an important component here of trying to streamline communication, right? In an organization like Partners, where we have people spread over multiple hospitals and multiple clinics and so forth, you really need to reach out and try to have as much participation as you can. So communication technologies, virtual communication technologies, is something that we have been using and we have had, a fair amount of success with. And then, as I mentioned, the implementation of automated, content validation. So you should try to use automation to try to improve the quality and the consistency of the knowledge bases as much as you can. Overall, right, you are looking for accuracy, you are looking for completeness, and you're obviously looking for maintainability, right? Because you can, and it's interesting because in our history, a lot of these knowledge bases have been initiated as research projects where people were trying to prove, right, that this type of intervention was extremely efficient or extremely would bring benefits to the patient. And obviously, more frequent than not, the answer was yes. The challenge, obviously, is the after effect, right? So, okay, now I have created this knowledge source. I have proven that it really is useful. How am I going to maintain it, right, over time? The drug-drug interactions, by the way, is one of those examples. And then the whole notion about risk in terms of incorrect or outdated content. If we look outside healthcare, if you look at knowledge management in a much broader level, there's a very interesting article from Fisher and Ostwald that came out in 2001. Try to have kind of a futuristic, view on knowledge management. And I think we can align, and the things that I bolded here in blue are the ones that I believe overlap with the requirements and the things that we are seeing, with perhaps the extension, perhaps the exception of the notion of improvisation. That usually doesn't go very well, in healthcare, if you try to improvise too much, right? Because one of the biggest issues is to try to not necessarily standardize in the sense of freezing, but really try to get people to converge towards, best practices. So we are seeing, most of these trends, and I believe we are, moving towards those things as well. The challenges are many, right? So I tried to summarize in a slide kind of the most important things. Clinical governance and stewardship are typically not well defined, right? So the liability from having decision support using outdated and incorrect knowledge is frequently not recognized. And it's interesting because the cost of not having decision support in some degree is also not frequently considered. What we are seeing from the incentives that are coming out of the government is that this equation is likely to change, and people are going to start to first educate themselves about what it is, and then will be kind of forced to try to rely on it more and more. Projects and resources, this shouldn't be a surprise to anyone, right? Clinical experts are frequently unavailable. There's limited commitment on that regard, and you end up doing this in competition with other activities. We've been, fortunate at Partners that we have had the opportunity to create a team and secure the resources, although we do struggle with the amount of work that has to be done and the number of resources that we have to tackle that. Maintenance is frequently an afterthought. As I said, I described the case where some of these more advanced types of decision support are created as research projects, and then you have to come back after the fact because they obviously don't want to turn it off, right? This is working well. Drug-drug interactions is important. It's reducing our medication errors. We need to be able to continue using it. And one of the pieces that we don't have, but is extremely important, is the whole notion of analytics, right? Having the ability to understand the impact and try to improve the process and the outcomes, by looking at how these things are actually being used. Availability of data. This was actually, there was a question at the beginning that talked about that, right? It's an interesting, perhaps a catch-22, if I'm using the term correctly, right? The notion that you need structured coded data because that's what determines how much decision support you're actually able to provide, right? Not only as a triggering mechanism, but when you're looking at things like workflow automation or clinical practice guideline, for instance, there's a heavy reliance on detailed clinical data that is typically not captured in a patient record in a coded and structured format. It's usually captured as free text, right? The challenge here is that data is expensive to generate at the point of care, and the benefits of decision support are frequently not tangible to the people that actually have to generate that data to begin with, right? So it's all a matter of workflow and at what point of the workflow you want to make the interventions. And then the dissemination of and exchange of knowledge assets also depends on data standardization. So if I'm writing a very simple rule, but that rule relies on understanding how a medication is prescribed and which code I'm using for that drug that I'm prescribing. As was said before, the structure of the data and the semantics of the data has to be understood. Consequently, right, when the data is referred to within the knowledge, right, that same problem is present. So you have to go towards acquisition of the data and then exchange of the data. One remaining issue is, as you become more and more sophisticated, then obviously the semantic expressivity becomes a big issue, and you expect this to grow over time. Cognitive aspects, we mentioned those, right? Another way to say, perhaps make the same point that Blackford made before, is this notion of attention economy, right? Being able to, you have more information than you can actually pay attention to and understand. So you have to be able to find information relevant to the task at hand. And that is extremely hard to do, but it's the essence of what a good clinical decision support intervention really is. And then there is some folks, Vimla Patel and others that have been studying the cognitive impact of introducing the computer as a mechanism to support decision-making, right? And it was said before, the results are not always positive. Context modeling, I said I was going to be, so this is the third time I come back to it. Real challenge, again, has to do with the notion of attention, has to do with the notion of appropriateness. So if I'm going to alert someone about the medication, right, that there is a drug-drug interaction, I have to know precisely when that intervention has to be, displayed. Because if I do it too late or too early, I'm not going to have the appropriate effect, right? So knowing what users are doing, what they have already done, where they are, and what they know is extremely important. As you can see, as this thing moves down, what they know is a very difficult thing to figure out, right? So you have to model context as it pertains to the clinician, the patient, the process, the clinical process that they are working on, the clinical setting that they are working on, right? The system, the information system that they are interacting with, and also, very importantly, the resources that they have available. If your intervention requires a specific type of resource that happens not to be available in that particular setting, right, then that intervention is probably not going to work the way you expect. Dissemination strategy is very important, right? This is a kind of a futuristic scenario that came out in a very interesting report looking at, kind of asking the the computer science community to try to help with some of the healthcare challenges, right? So this is the notion of a clinician, using an electronic health record in his or her clinic, subscribing to some literature alert, figuring out that a new guideline came out, and that guideline now includes a new drug, and makes the decision that he wants to implement that guideline in his or her own practice, right? Downloads that guideline into the EHR, so that's a very interesting mechanism. Obviously, we don't have that today. And then that system is smart enough to receive the new piece of knowledge, right? Reorganize itself, right? In terms of action flow charts and workflow models and whatnot. And there we go. You start using it, right? As I said, it's sort of a futuristic view, but it's definitely what we should be aiming for. A similar model obviously would include if instead of being a clinician, it's a patient, right? At home, using his or her personal health record, you could imagine that a similar deployment strategy could be in place. I'm not going to try any analogies from what we have nowadays in terms of music and videos and whatnot, but I think you guys can kind of follow the thread. So if I think of a large-scale clinical knowledge management system, right? Someone has to be involved with the development of the CDS content. That's what I talked quite a bit up to this point. But the things that are crossed with kind of red X's here are the things that we still don't have, right? So I don't really have a standard format that I can distribute this knowledge content to other systems, right? And I don't have a place where I can go to download that knowledge content, right? And more importantly, perhaps, I don't have EHR systems that can be configured by the end user to the degree that is necessary here. So one of the questions that keep coming back is, what will really differentiate? What is the future of a clinical information system? Is it really something that just automates the process, that it's really very simple to use, or is really a system that has the ability to execute very advanced CDS functions, right? We obviously think it's the last one, if it's not clear up to this point. So we've been working a lot in the notion of dissemination. This is a project that Blackford is actually the PI, right? So we created what we call a knowledge management portal. We have funding from the Agency of Healthcare Quality and Research, IHRQ. And we are basically making available in this portal, right? You just go to this URL, you accept the terms of use, and you have access to our guidelines. You have access to those guidelines represented in code in a declarative model in XML. And you have instructions on how to use and how we derive those guidelines and so forth. So we are trying to make an effort to create at least a dissemination model that we think would be beneficial for other organizations like partners. And then try to engineer these knowledge artifacts in a way that is reproducible. Making things, perhaps more complicated, right? We've been talking up to this point on what I would describe as the patient care cycle, right? So everything that I talked, and to a large extent, the reason why I prefaced the notion of a knowledge management system with the word clinical is because the focus for us is very much on the patient care, the bedside, right? But as you can imagine, there is also obviously a clinical knowledge system for research, right? What happens in what we describe, the bench, right? And there's clearly also a knowledge management system for public health, for the population, right? So being able to integrate these three systems in a way that is meaningful is obviously a huge challenge. And it is a challenge that has been recognized, right? So this is a quote from Dr. Dazal, if I'm pronouncing his name correctly, which is the CEO of the Duke Medical Center. So the academic medical centers obviously recognize this challenge and realize that they need to become very effective in doing that. So factors justifying quantity of knowledge, right? We've talked about the knowledge explosion. The notion of distributed care, a distributed care delivery process, which is today very fragmented. So we need to engineer this in a way that you can go beyond the organizational boundaries and you have learning opportunities. Global trends towards knowledge socialization, getting patients involved. Patients are obviously very active, should be very active knowledge consumers as well. And you can only have shared responsibility if you have obviously proper understanding. And then the notion of maintenance, right? Long-term maintenance right? Diversity and quantity makes traditional models unrealistic. We have to be able to do this in a collaborative and distributed mechanism. Acknowledge folks that have helped with these ideas and also with these slides. I have left here a few additional references, particularly for the students. If you are intrigued with the notion of a clinical knowledge management system, you can get some additional information from these sources. Great. Thank you very much.